GI pathology, the esophagus. All right, so I know you're probably wondering, I'm skipping over the oral pathologies. The reason behind that is because I don't think it's worth my time for me to review it for you guys. Just take the time to look it over yourselves. I would say just like reread like the squamous cell carcinoma and sialolithiasis probably. To me, it was something that I wasn't, I didn't do too much studying on. So, to each your own. It's up to you whether you want to do it or not. But I'm going to go into the esophagus. The first thing I want you to take away from the esophagus is achalasia. So what is achalasia? Achalasia is failure of lower esophageal sphincter to relax, okay? So you have very high pressures at the lower esophageal sphincter, okay? And the reason behind that is because you have degradation of inhibitory neurons in the myenteric or Auerbach plexus of the esophageal wall at the lower esophageal sphincter. So you can't release nitric oxide or VIP to help alleviate that pressure, to help inhibit the neurons located there. And so the myenteric and Auerbach plexus is just going to be continuously causing constriction of the muscle that's located at the lower esophageal sphincter. Okay, so decreased number of inhibitory ganglion cells with increased lower esophageal sphincter tone kind of is the overall pathophysiology of achalasia. All right. Now, achalasia could be caused by, the primary thing is going to be idiopathic, but secondary, it could arise from Chagas disease. Treponema cruzi is the infection. And what they want you to know specifically is that the patient is going to present with progressive dysphagia to solids and liquids. Okay. Now, it's associated with increased risk of esophageal cancer, and what they will do for diagnostic factors is manometry findings, okay? So what you'll see is as the patient swallows, the food will go down, and you'll see on manometry, it's a normal pressure, and then right when it hits the lower esophageal sphincter tone, it's going to see very large pressure, very large resting pressure at the lower esophageal sphincter, and that's going to be very helpful in diagnosing achalasia. Another helpful way to diagnose achalasia is barium swallow. The barium swallow is going to show a dilated esophagus, all right, a dilated proximal esophagus with an area of distal stenosis, okay? And it's going to be called the bird's beak imaging, okay? So on barium swallow, you will see bird's beak imaging, all right? And that just essentially means that the lower esophageal sphincter has become so tight that you could kind of see the flow of the barium swallow become much narrower. And you could see a photo of that. That's very high yield. I'll show you a photo of it. Now, the way that they want you to treat it is you could treat it with botulin. Okay, so botulinum toxin is going to be helpful because it's going to essentially paralyze those neurons that are constantly constricting. And so when you paralyze them, it will relax finally the lower esophageal sphincter. So you could treat it with botulin, all right? So overall, achalasia, what you need to know, it's a decreased number of inhibitory ganglion cells, which leads to an increase in the lower esophageal sphincter tone. You're going to see it potentially in Chagas disease. The patient is going to have progressive dysphagia to solids and liquids. You're going to diagnose it with manometry findings and barium swallow with bird's beak imaging, and you're going to treat it with botulin, all right? Next, for other esophageal pathologies, is going to be GERD. So GERD is essentially the opposite. It's going to be decrease in lower esophageal sphincter tone compared to achalasia's increase in lower esophageal tone, all right? Now, it's going to present with like heartburn and regurgitation and dysphagia, right? A patient, I'm sure everyone knows people that have GERD, all right? You know the presentation and the symptoms associated with it. Now, it can be associated with asthma. Adult onset asthma is very odd. So if you see an adult onset asthma, it can be associated with GERD. Lower yield, but it could be. Now, it can lead to complications, specifically Barrett's esophagus. And we'll talk about Barrett's esophagus later on, but GERD is one of the risk factors for Barrett's esophagus. Next is esophagitis. Okay, so esophagitis is just inflammation of the esophageal mucosa. All right, now there's different types. One is going to be reflux or erosive esophagitis. Okay, this is the most common type. It's usually secondary to GERD. Okay, so GERD can cause inflammation of the esophageal mucosa, leading to reflux or erosive esophagitis. All right, very important, very straightforward. Okay, now patients can present with eosinophils. Okay, so patients that have reflux or erosive esophagitis have potential eosinophils present, all right? Next is medication-induced esophagitis. So this is patients that could be taking, bisphosphonates or tetracyclines. Those are the two highest yield ones, are bisphosphonates and tetracyclines. That can lead to medication-induced esophagitis or inflammation of the esophagus. Okay, so remember, bisphosphonates and tetracyclines. Next is eosinophilic esophagitis. What you need to know about eosinophilic esophagitis is that on EGD or on imaging of the esophagus, if you do an endoscopy, you're going to see stacked ring-like indentations with linear furrowing, okay? So that's very, very important, okay? The the stacked ring-like indentations is very high yield, and it's pathognomonic for eosinophilic esophagitis. Okay, so these esophageal rings and the linear furrows on endoscopy. All right, it's immune-mediated and it's eosinophil predominant. Okay, so on histo, it's going to show eosinophilic infiltration of esophageal mucosa. But remember those stacked ring-like indentations with linear furrowing. Okay, that's very high yield for eosinophilic esophagitis. Another cause of esophagitis would be infectious esophagitis. The first one's going to be Candida. Candida is the most common, and what you're going to see is white pseudomembranes, right? For Candida, makes sense. The second one's going to be HSV1. HSV1 is going to be punched out ulcers, punched out hole-like ulcers. Okay, it's going to be circular. Compared to CMV esophagitis, those are going to be linear ulcerations. Okay, so they want you to differentiate Candida versus HSV1 versus CMV esophagitis, and they're very simple. It's based off of what you see on endoscopy. So linear ulcerations is CMV, HSV1 is going to be punched out ulcers, and Candida is white pseudomembranes. All right. Now, all of those are associated with immunosuppression. All right. Lastly is going to be corrosive esophagitis. So it's going to be patients that, could one way or another inhale or take in any caustic ingestion. All right. And it could be like an alkylative agent that can lead to corrosive esophagitis. Next is Plumer-Vincent syndrome. So I remember a Plumer-Vincent syndrome question on, I think it's the CBSE, like the final CBSE, and I was like, no way they're asking about Plumer-Vincent right now. And so what it is, we already discussed it in Hem-Onc, but it's the triad of dysphagia, iron deficiency anemia, along with esophageal webs. The patient can also have glossitis, or inflammation of the tongue. Okay? So once again, if you see the triad of dysphagia, iron deficiency anemia with esophageal webbing, and it's associated with glossitis might be there, might not be there, then think about Plumer-Vincent syndrome. Okay, the iron deficiency anemia with weird esophageal kind of pathology should kind of hone you in on Plumer-Vincent. It's so weird. I don't remember getting any question ever on it, but that's what made it so much weirder for me, seeing it on one of it was on a really important exam. I forget what exam it was. So next is going to be Mallory-Weiss. Mallory-Weiss is going to be kind of a partial thickness. Okay, partial thickness longitudinal laceration of the esophagus or the gastroesophageal junction. Okay, and this is confined to the mucosa or submucosa. It does not go deeper. Okay, that's something different. Mallory-Weiss is just going to be confined to the mucosa and submucosa. It's going to be a long laceration, and the reason behind it, it's usually due to increase in intra-abdominal pressure. So if a patient has recurrent vomiting, severe vomiting, they can have, most likely alcohol use disorder or bulimia. That's where you're going to see Mallory-Weiss. And the patient's often going to present with hematoemesis. Okay, so they're going to have blood-streaked vomit and potential back pain. It's going to be Mallory-Weiss. Now, a key thing you have to differentiate this from is esophageal perforation or Borhave syndrome. Borhave syndrome is transmural. Okay, it's a complete rupture, a complete laceration that ruptures, transmural. It's a violent retching rupture. Okay, so if you see a patient that's violently retching, then it could be Borhaven syndrome. Now, the way that you differentiate esophageal perforation from Mallory-Weiss or Borhaven from Mallory-Weiss is you're going to see air in the mediastinum, and there's going to be subcutaneous emphysema under the skin and at the neck. So you'll have crepitus when you're pushing on areas in the neck or the chest wall. You're going to see air on imaging. If you do CT scan, you're going to see little pockets of air. That's going to be esophageal perforation or Borhaven syndrome. Okay. Remember, Mallory-Weiss is not a full laceration. It's not transmural. It's only confined to the mucus or the mucosa and the submucosa. All right. Esophageal perforation is the whole thing. Esophageal perforation is a very, very scary disorder or disease. You have to take them back to surgery immediately. Okay. So take a look. There should be a CT scan. Take a look at what that CT scan looks like when you have air within that region with esophageal perforation or Borhave syndrome. Okay. Because they will show you photos like that. That's similar. All right, so that's your difference between Mallory-Weiss and esophageal perforation. Both can be caused by severe vomiting, but esophageal perforation is even worse, severe retching, violent retching continuously. Okay. Next is going to be esophageal varices. We already discussed this is going to be dilated submucosal veins. Okay, it's going to be in the lower 1/3 of the esophagus, and it's usually secondary to portal hypertension. Right, we discussed that already, and it's going to be commonly seen with patients with cirrhosis. Now, it's going to be the left gastric vein that's usually going to be involved. And if those start to bleed, it's very scary because that increases your risk of just internal bleeding and you could die. Okay. You have distal esophageal spasm. This is what you want to know is it's an impaired neuronal inhibition. So very similar to our achalasia, but you have normal LES pressures. So that's the difference. So although it's impaired neuronal or neural inhibition, you will have normal LES pressures. And on barium swallow, you will see a corkscrew esophagus. So take a look at what a corkscrew esophagus looks like on barium swallow, and that is very high yield for distal esophageal spasm. Once again, they want you to know that it's impaired neural inhibition with normal LES pressures and corkscrew-like esophagus. Okay? Now, scleroderma, esophageal involvement. This is the last one. We'll talk about scleroderma in the room, I think the room section later on. But all that happens is that you have esophageal smooth muscle atrophy. So what happens is that you have a decrease in the LES pressure, and you get dysmotility in the distal esophagus. So it's a part of the Crest syndrome, and we'll discuss the Crest syndrome later on. So I don't want to kind of belabor the point right now. All right. So lastly, for esophagus, we need to talk about Barrett's esophagus and esophageal cancer. So first, for Barrett's esophagus, what this is, and think back to pathology from pathoma, right? It's just metaplasia, okay? So it's the changing from the lower esophageal lining from squamo-columnar epithelial junction, at the squamo-columnar epithelial junction, right? And so what happens is that you have a change from non-keratinized stratified squamous epithelium to columnar non-ciliated with goblet cells, okay? So it's replacement of that epithelial lining. And it usually is secondary to increase in stress, right? Remember back to pathology, if you have increase in stress, your cell types will change in order to accommodate that stress level, okay? So one high yield association or stressful association is GERD, okay? So if you have GERD, you're gonna have constant amount of acid coming back up the lower esophagus, right? Because the lower esophageal sphincter tone is decreased. So it allows for splashing of acid back into the esophagus. So that acid leads to increase in stress in that area, which causes the metaplasia. Now, this can lead to an increased risk of esophageal adenocarcinoma if left untreated. So a long time of GERD, a long history with GERD that's untreated, that can be a risk factor for esophageal adenocarcinoma. All right, so that's just Barrett's esophagus. So let's kind of dive into esophageal cancer. Esophageal cancer is very, very, very high yield. You need to know esophageal cancer. So let's start off. First off, it presents with progressive dysphagia. So first, the patient struggles to eat solids. And so they change their diet to only like drinking like smoothies and like soups and stuff like that. And then it continues to progress into liquids. So first solids is hard to eat, then it becomes liquids. So that's known as progressive dysphagia. That's seen in esophageal cancer. The reason behind that is because the cancer is going to start off small, and as it continues to grow, it takes up more space in the esophagus, making it harder and harder to kind of have food pass through. So you're also going to see weight loss because of that progressive dysphagia. So those are your two key kind of factors, your signs, all right? Now, there's two types of cancers you have to know. You have squamous cell carcinoma and you have adenocarcinoma. Squamous cell carcinoma is usually going to involve the upper 2/3 of the esophagus, whereas adenocarcinoma is going to involve the lower third, okay? That's the first important thing, all right? So now let's kind of break up squamous versus adeno. So squamous cell, what they want you to know for risk factors is alcohol and hot liquid drinking, smoking, and smoked foods. For adenocarcinoma, the risk factors are GERD, obesity, tobacco usage, and Barrett's esophagus. Okay, the way that I remember this is that since squamous cell carcinoma is the upper 2/3, it's going to be everything that passes down it. So you have alcohol and hot liquids that pass by it and burn the upper 2/3, but it gets cooler towards the lower third. So it's not going to cause adenocarcinoma, it's going to cause squamous cell carcinoma because it's going to be first affecting the upper 2/3. It first hits the upper 2/3. Number two is smoking. Smoking, they want you to mainly know the risk factor is associated with squamous cell carcinoma, although it can cause adenocarcinoma. But the way I remember that smoking is highly associated or closer associated with squamous is that smoke rises. So it's going to affect the upper 2/3. Lastly, smoked foods, same thing in my mind. Smoke rises, so it's going to affect the upper 2/3. Adenocarcinoma is the lower third. So you're going to have affected, like problems are going to usually be stomach related, gastric related. So GERD, because the stomach's right there at the lower third of the adenocarcinoma. So GERD is going to affect the lower third, and it's going to be adenocarcinoma. Obesity, same thing. Okay, so since you have such an obese body, it's going to push the acid from the stomach up towards the lower third of the esophagus, leading to adenocarcinoma. Tobacco usage, since it's not smoke, it's just the tobacco products are going to pool towards the bottom third, and that's going to be adenocarcinoma. And lastly, Barrett's esophagus obviously is going to be the lower third, so it's adenocarcinoma. So those are the key takeaways that I want you to know for squamous cell versus adenocarcinoma. Squamous cell is upper 2/3. I want you to know those risk factors that I listed. Adenocarcinoma is lower third, and I want you to know the risk factors associated. Now, last thing. Histology on squamous cell carcinoma is going to show keratin pearls and intracellular bridges. Duh, right? All type of squamous cell carcinomas, no matter where in the body, will have keratin pearls. Okay, so that is very high yield for you to know. All right. Now, that's pretty much it for the esophagus. The last thing I want you to know, and this is more of an anatomy thing, is that the esophagus is going to pass through the diaphragm, right? At the esophageal hiatus at the diaphragm. Do you remember what level? I ate 10 eggs at 12, right? So I ate 10 eggs. So at T10, that's where the esophagus is going to pass through the diaphragm. But something important follows next to the esophageal hiatus, okay? That goes with the esophagus, and that's the vagus nerve. So the vagus nerve transverses through the esophageal hiatus at the diaphragm. That's just an anatomy question that they want you to know because there could be associated pathologies with that as well. So that's the esophagus pathology. Next, we're going to be learning about the stomach pathology.